So thank you so much for making this happen today, and I really appreciate all organizers to put great speakers together. And our session will be focusing on combined therapy. We've been talking about different approaches with stimulation, and we have three fantastic speakers: Dr. Candance Floyd from Emory, Dr. Anthony Windebank from Mayo, Dr. Yury Gerasimenko from Paul Institute and University of Louisville. And unfortunately, our fourth speaker, Mackenzie, she wasn't able to make it. She has some health issue today, and she's the person with actual experience. She has spinal cord injury. She was implanted with epidural electrodes to control her symptoms time ago, and we had extremely productive discussion with her about pros and cons on all those questions we will discuss today. So I really hope that we can get better and get her feedback. So, so again, this session is attempt to start discussion on how we use stimulation in combination with other modalities, because we know that it will not be used alone. It will be some other therapies. And over last few days, I think most of the speakers have been saying that we have many unknowns about impact effect of stimulation. Again, I will not repeat them, but it was very consistent. And I also hear two opinions about potential studying combined therapy. One, that we don't know much about spinal cord stimulation. And because of this, studying combined therapy is too early. I'm not sure if Dr. Peter Grant is here, but I think he made a statement that I would think about this, but I'm not ready to apply to implant for myself, right? Because too many unknowns. Again, I hope I'm doing the right quote. But another opinion, I also hear the same way, that spinal cord stimulation or some regenerative therapies will be approved sometime soon. Some companies expect that each FDA approved will be done in a year, some in 5 years, but it's coming. And as soon as it will be happen, we need to discuss about what type of combination, what type of integrated therapy. So again, if this is the case, it's maybe too late. So again, we either too early or too late, and I guess we kind of need to start this discussion where we are. So, and one of the key moments I want to kind of emphasize that moving from rat to human was extremely fast for spinal cord stimulation. And most of the ideas that have been tested in rats, they've been tested directly in human with spinal cord injury. But when we talk about regeneration, when sizes matter, when distances matter, rodent model is not the best. And then we talk about some translation model. And I hope to hear thoughts of our first speaker, Dr. Candance Floyd, about optimal model. What could be done in this way, how we can use a translational peak model. And from my personal experience, we switched from a rat model to peak because of some early studies we did. So in one study, we actually combined both models in the same approach. We used MSC, modified to express some growth factors, and we did pretty much the same for rats and then for pigs. And we saw clear difference in improvement in rat model, but not in pig. Because of this, in other studies, we realized that we need to study more impact of regenerative therapy in pig model, which is closer to human in many other ways, actually. And we did a line of different cell therapies, different growth factors combined. Then we introduced spinal cord stimulation on top of the regenerative therapy. And again, I will not go through all those details, but at some moment we realized that there is some limitation on cell therapy, and over the last few years we've been trying to focus on another type of vehicle, white blood cells modified to express growth factors. And we know that they can travel injected IV to brain and spinal cord injury site. And currently we're trying to move this direction to see how much we can get improvement from cell therapy combined with spinal cord stimulation, and we actually doing this on pigs. So another question, and this would be our second speaker, Dr. Windebank. the question how we combine and what we combine with spinal cord stimulation. Let's say we conventionally use stimulation with rehabilitation therapy, right? And but then on regenerative side, we have scaffolds, we have micromolecules, we have different type of cell therapies. So where we go with this, and what our potential combination, most effective combination? I think it's something we hope to see, to discuss today. And yeah, I hope to hear Dr. Windebank's thoughts on this. So, and then I just want to quickly say that we did quite a complex study on combining all those factors, and we found that rats that had been implanted with scaffolds, with cells, with expressing growth factors, and they've been trained to step on treadmill, they're actually doing much better compared to rats that had been just stimulated. But then after transaction, we still see this effect. That means that new fibers, they make some changes in circuitry, and the circuitry became active to produce optimal outcome. And our final talk will be from Dr. Yury Gerasimenko. And I guess this question, what is neuromodulation, how it does work, right? It's still a question. And this is probably one of the most visual example of CPG, central pattern generator. You see just 3-4 segments of spinal cord in animal connected by nerves with legs, and you see very coordinated stepping. This stepping facilitated by chemical that was dropped on the spinal cord. Again, this is basic concept of central pattern generator that we activate with spinal cord stimulation. And another, probably the most visual evidence of CPG in human, it's from study of Yury, Gerasimenko and Dr. Dmitrievich that was done in 1998. It was published. And here you can see a patient who is completely paralyzed. And when electrode was introduced to the epidural space and slowly moved, a specific area in the spinal cord, when was stimulated, caused this type of very clear alternating movement between flexor extensors, right, left legs. Again, non-volitional, but very clear modulating, showing us that there is a CPG in human. So anyway, it's two most visual examples of CPG, I think. And I really hope to hear from Dr. Gerasimenko his thoughts on the best modalities that potentially could be combined to improve impact of stimulation. And again, from my personal experience, I think the most difficult and most intensive study we did so far that include multiple centers is when we enrolled patients with spinal cord injury and going through complex diagnostics of pathways which could be present after injury. Then we tested effect of non-invasive transcutaneous stimulation with different type of tests, upright, sideline, balance. Then those patients been trained with non-invasive stimulation for at least 8 weeks, and then it was made decision to proceed with epidural implantation. Yeah. And over this time, we learned that actually epidural stimulation and transdermal stimulation, they're not the same. Same patients report different outcome. And again, I just want to say that this is kind of what we found so far. So anyway, so I hope at the end of the discussion we can talk about all those different components that could be combined with epidural or non-invasive stimulation. And I want to introduce our first speaker, Dr. Candance Floyd.
So today I'm going to talk to you about pig models. You're probably going to learn more about pig anatomy today than you bargained for. But the reason I want to talk to you about this, as soon as I figure out how to advance the slides, is because I think that pigs can be a very useful tool for you, and I also want to present to you a very collaborative platform. So I want to start by identifying myself. My pronouns are she, her, and hers. I like to give a descriptor because I think it's an inclusive way to start a talk. I consider myself to have shoulder-length red hair. You may or may not agree with that. I have green eyes, and I'm about 5'5" and size large. My lab is focused on inclusivity, I can't say the word, and diversity, and we welcome all viewpoints. And at the center of our efforts is this idea that you have experienced in this conference in, I think, a very robust way, is that we have persons with lived experience really helping to guide us in a meaningful way. We have persons with lived experience working as data curators in the lab, as well as providing us with insight and information. One of the other things I'll talk to you about today is that this is a highly collaborative offer. This is an offer for collaboration. And if you're interested in anything I'm talking with you about today, please just email me. That's the first step. So in several places during the talk, I'll have my email listed down there for those of you that like to take pictures of the slides. So we've heard about this many times in this symposium, and there are many people with lived experience that can describe to us that in the field of neurotrauma, including the fields of brain injury and spinal cord injury that we're going to talk about today, there's been this lack of translation. There's an ongoing effort to overcome this. We've talked about many kind of valleys of death and things to overcome to improve translation. So what I want to present to you today is this idea that perhaps we could use these large animal porcine models as an intermediary between discovery, but also to teach us things that will improve translation and effectiveness in the clinic. So this idea that translation is just a one-way street from discovery in rodents into human applications is not our version of translation. Our version of translation is that it's a reciprocal conversation where we're learning things and we're applying things. So I use a term a lot I call back translation, and what I mean by that term is that I'm taking something that's used in a clinical setting and bringing it back to the laboratory setting to improve the translational viability of our findings. So I'm going to talk to you today about a lot of things. But essentially, the idea here is that we have a new center at Emory. I call it the Entire Center. Just founded it, just started about a year ago. And the concept of that center is to provide tools to the research community that you could use, that we could work together in a collaborative way to rapidly advance our knowledge and our translation of novel therapies for persons with spinal cord injury or neurotrauma. But I'm going to focus on spinal cord injury today. So the talk will be a little bit unusual because really what I'm going to talk about today are tools. And so what I want you to leave here thinking about is how could you use tools that we're providing to you as a resource and improve the development of novel therapies. So I'm going to kind of joke around about this and say, basically, if you think about this, what the Entire Center has done is established a large animal lab that you could use without having to do the hiney washing yourself. So that's a good thing if you're a student in the lab. So we're going to talk about some of the elements of the model. So first we're going to talk about use of spinal cord injury in both sexes. We're going to talk about image-guided neurosurgical techniques and using MRI outcomes as functional outcome measures. Telemetry devices for autonomic function, mean arterial pressure. We'll talk about locomotion assessments. We speak PIG, which I'll tell you a little bit more about. Also, we've developed scales for evaluating pain from the PIG's perspective, and then emerging tools as well for evaluating ADLs. Okay, so again, this is the idea. When I talk about translational research, when I talk about translational research, we're talking about that interface between clinical applications and basic research. Our overarching premise is that if we provide really solid injury models that have strong rigor and reproducibility in this translational research setting to the research community, so in collaborative use, that we should be able to accelerate the discovery of new therapies. So, there's two things that are very important to us in my lab, and it's people and pigs, and some days it's not necessarily in that order. But what I want to explain to you is a little bit about our expertise of the team. And so we have a team assembled and pictured here. This is a relatively recent picture of the group that include scientists and veterinary technicians. We actually have several veterinary technicians that work on the team that provide really expert animal care. So myself and the leadership members of the team are pictured here. I'm in the middle. It's Dr. Lonnie Schneider, who is our quality assurance professional, and Tracy Najelko. The three of us are all experts in good laboratory practice. And again, we have quality assurance on the team. The rest of the team are experts in providing things that are very similar to what's provided in a human clinical setting. So we have a pig neurocritical ICU that is just exactly as it sounds, right? So we have veterinary technicians that sit 24/7 pig side, provide neurocritical care for those animals in a setting very much like a neurocritical ICU. It's a little bit of nursing, it's a lot of daycare. Those are awake, behaving animals. And so there are a lot of interventions that can be done at that stage. We also have the ability to do behavioral assessments, which I'll talk to you more about. I'll call it behavioral pharmacology. But importantly for drug development, when you're thinking about combination therapies with neuromodulation of drugs in development, we can conduct longitudinal sampling. So that means put in Amayas, put in lumbar drains, do cerebrospinal fluid sampling, do blood sampling, do sampling of urine and other aspects that would be important to understand pharmacokinetics and pharmacodynamics of drug interactions with your neurostim applications. We have tools and well-validated tools to measure spasticity in the pig model. We can do urodynamics in the pig model. We use clinically based protocols for urodynamics. Our procedures for recording and for conducting the experiments, we use a complete digital laboratory notebook system, and all of that is 21 CFR Part 11 compliant, meaning that we can use that with GLP. Again, we have grant writing expertise and administrative support, and then we're just compassionate about animal care. So you really would have animals that are in very good hands. So why use the pig? So we've talked a little bit about pig, and folks have mentioned that they've used pigs in some of these experiments, but I just wanted to revisit the concept of pigs as a translational intermediary. So you probably realize this, and you probably remember that in biomedicine, pigs have had a large and important role. Some of the main accomplishments have been in the area of coronary artery disease. As you know, pigs have been used, pig valves are used in heart implications. Pigs are really great for infectious disease as well. So the immune system of a pig is much more human-like than the immune system of a rodent. And pigs have a lot of similar responses to infectious disease, toxicology testing, and they're used extensively in vaccine development. I don't know if you knew this, but the skin of pigs is almost identical to that of the humans. So they don't have fur, they have hair. And so identical that in some situations, particularly in patients with burns, that pig skin can be used in human skin for grafting. There are several models of pigs that are available. Again, so if you're interested, I think one of the ones that would be very interesting to this community would be, there's a great pig model of metabolic disease. And so if you're interested in trying to understand metabolic disease influences with a neuromodulation or a drug therapy. Pigs are, when you think about their physiological characteristics, again, if you haven't spent a lot of time with pigs, so they're monogastric. So sometimes people say, do they eat hay? You know, no. Pigs are omnivores, and they eat everything that we eat. So they're monogastric. So all of the work that we talked about with microbiome, the microbiomes of pigs are very similar to that of humans. They can eat a human-based diet. We've done studies where we took the NHANES 50 percentile of what Americans eat, and we developed a pig diet that was exactly what Americans eat and gave those pigs that diet, and then evaluated effects of spinal cord injury, or effects of pain after spinal cord injury. So again, really robust models for human metabolism. Interestingly, for pharmacokinetics and pharmacodynamics, pigs are an outstanding model. So when we think about the combination therapies, right, where you want to understand how your neuroplasticity enhancing drug or your drug that's going to prime the nervous system to receive neuromodulation, how those drugs will work in the setting of your neuromodulation, pigs are an outstanding model. Because again, we can take these serial samplings too. And then it probably goes without saying, because you probably think of that saying of eating like a pig, pigs are a really good model for obesity. They would just love to eat. The pigs will do almost anything for a jelly bean or a marshmallow. And that's something we use in the lab all the time. So in addition to these similarities with human as this translational intermediary, pigs afford a very complex nervous system. And what that means is they have complex behaviors. And so not only are their brains very highly developed, they're gyrocephalic, they have a lot of complexity. The brains are actually more complex than rhesus monkeys that are often used as non-human primate research. So this complex physiology then enables us to understand the effects of these combination therapies or neuromodulatory therapies on a complex system. So that's fantastic. So the brain and the spinal cord and spinal structures are more human-like. So in our laboratory, we use things right off the shelf. And what I mean by that is we'll use things that are designed for a clinical application. So if you're designing a stimulator or a stimulation system, you don't have to make it so itty-bitty that it goes in a small mouse. You can do it in a larger size. We don't need to do a scale-up type of experiment. We can test that at a size that's human relevant. So this is an example of a study we did some time ago, and I wanted to illustrate the use of image-guided neurosurgery, which is a really important tool for implanting the stimulators in a precise location and for evaluating. We also use image-guided neurosurgery for injections of cells, injections of gene therapies. So in this study that's pictured here in this multi-panel, we used the stealth system to do image-guided neurosurgery in pigs. And our goal here was to evaluate the location of the cortical spinal tract to try to get some better understanding of the motor tracts in pigs. We also, whoops, I didn't mean to do that. Sorry, I'm going to go back one more. See if I can work this. Okay. What we also do now is we have a brain site veterinary system, and we've worked with a human system with ClearPoint Neuro. We basically use a system right off the shelf in the pig. So we have several methodologies that we can do that. But for this study, what we did is injected a tracer dye into the motor cortex, very similar as has been done for many decades in several different animal models. And we asked the question, where is the cortical spinal tract located in the pig compared to where it is in the human? And it was a very simple study in some regard where you can see these are fluorescently labeled axons ascending through the spinal cord. This is an example of the motor cortex area where the cells were labeled. And what we found in this study is the cortical spinal tract, the lateral cortical spinal tract is located in the pig in a location that is similar to that in the human and different from that in the rat. So just a very simple example to show you that the anatomy of the pig, the neuroanatomy of the pig's spinal cord, is more human-like than that of the rodents. So the spinal cord model that I'll give you a few examples that we use often in the laboratory is that was originally discussed and described by Brian Kwan and his team. It's a contusion compression model. So what you see here is a picture of a surgical preparation. The spinal cord injury device is mounted with pedicle screws to the spine of the pig, and then the two weights are dropped to impact. We use a mid-thoracic level in this type of injury. So there's a 50-gram contusion, and it's followed by a 5-minute compression at a 100-gram weight. So it causes a very clinically relevant injury, and the pigs are quite impaired. One of the things that we have been working on in the lab for many years is this idea that sex as a biological variable is very important. So I don't know how much you know this, but we'll drill into this for just 1 second, is that as you probably are aware, the National Spinal Cord Injury Statistical Center has shown that about 78 to 80% of the persons that have new cases of spinal cord injury in the clinical population are male. Now, interestingly, there's a disconnect between what's done in the preclinical modeling arena, because almost everyone uses female animals to model a male population. Why, do you ask? Why, yes, Candace, why was my next question. And I think a lot of the reasoning from that is because the bowel and bladder management in female animals is significantly easier than it is in male animals. But there are probably other historical reasons. And so this graph shows, it's a nice representation of the differences in sex between preclinical models and clinical models, looking from this group, from Dr. Ginsel's group. And they show that about 48% of preclinical studies are in female, about 11% are in male, and about 9% are in both. So we thought it was really important to be able to study the spinal cord injury outcomes in both male and female animals. And there are a few things about pig anatomy that you didn't want to hear, but I'm going to tell you anyway. And so male pigs are typically castrated near birth. And so oftentimes you have to make special arrangements with the farms, which we do, to have an available supply of gonad intact male pigs. The other thing to know is that pigs have a sigmoid flexure in their penis, which makes clean intermittent catheterization very, very difficult or impossible. And so to use male pigs in a study, you're going to have to develop techniques to manage bowel and bladder, and we do that with a cystotomy and a suprapubic catheterization. So our question here was, do sex differences affect recovery in pigs? And one of the reasons that we were interested in understanding this is because the estrus cycle in pigs is very similar to the estrus cycle in humans. So in rodents, the estrus cycle is only a few days, and it has this kind of one peak, I can get my pointer back, one large peak of estrogen. But in humans, if you look at the human menstrual cycle, the estrogen has a different fluctuation pattern, and the cycle lasts for about 28 days. In pigs, this is our data showing you the hormonal levels across the cycle. What you can see is that the estrogen cycle in pigs is much more human-like, as is the progesterone cycle. So if we wanted to look at sex as a biological variable, some of the innovations are, first off, we can do male pigs, which very few people do. And secondly, we can evaluate the estrus cycle. So I won't get into this full study of data because we don't have quite enough time today. But the bottom line is that interestingly, it didn't make difference in our study if the pigs were injured in high estrus or low estrus in their cycle. Didn't make a difference on motor outcome. And it didn't make a difference in the study on motor outcomes if they were male and female. So, but the interesting data in the study is coming out in a paper soon in collaboration with John Ginsel. The immune responses and the pathophysiological responses between the males and the females were different. One of the other things I'll say is that this is using a classical way to evaluate locomotion in pigs. And in collaboration with Dr. Ann Parr, we are developing, it's a pedal, the pigs press, get a jelly bean, right, by pressing a pedal. And that enables us to evaluate volitional movement. Again, in a back translation paradigm from how these are evaluated in humans. What am I, about 3 minutes? Yeah, I'll go quick. Okay, so one of the things we were quite interested in is understanding how to evaluate pain in pigs. And again, we've talked about spinal cord injury and neuropathic pain, so I'm going to skip some of this for time. But the gap in knowledge is that I need the pigs to tell me when they're in pain, and I want to hear about their pain experience. So how in the world do you do that? So, in humans, this is kind of what you're used to, right? Some kind of scale. If you go into the emergency room and you have some kind of pain, you want to tell them it's 500 on this scale so you don't have to wait forever. That's the idea, right? So we want to have this type of 0 to 10 or some type of evaluation scale. Excuse me, I did that twice. That's a picture of my collie. He's a very vocal animal, and he has taught me how to speak collie. So the idea was maybe I could learn how to speak pig. That's a picture of the golden retriever. He gets sassy when you talk about the collie and don't talk about him. So that's exactly what we did, is I took a sabbatical in bioacoustics, and I learned how to speak pig, and I'm actually quite fluent. So we have studied, now we're up to over 6,000 vocalizations in pigs across different laboratory settings. And I don't have time to get into the details of the vocal classes, but what I can tell you about how pigs vocalize is that all pig vocalizations are in our audible range. So you can just use like GarageBand stuff to study this, right? You don't need any specialized equipment. And I think you can look by these spectrograms. Pigs grunt most of the time. You're like, thanks, Kenneth. Thanks for telling me pigs grunt. I didn't know that, yeah. Pigs grunt most of the time. Occasionally, pigs squeal. And you look at that spectrogram, and you can imagine what that sounds like. And it's also a readily identifiable biomarker, right? And let me just tell you, pigs scream. And a pig scream is a readily identifiable sign. And what we have identified is that as the stimulus intensity increases, the vocalization of the pig is a pure signal, and it can be linked to pain and distress. So we have developed a porcine-evoked pain scale where we can evaluate both the pig's opinion of pain, right, their supraspinal indication of pain, as well as other outcome measures for pain. And we have validated this and are continuing to validate this in several models, including spinal cord injury. We use some quantitative sensory testing assessments. Those are back translated again from the human methodologies to assess pain. We can use that in the spinal cord injury models. So now think about your combination strategy of neuromodulation with a drug plasticity enhancing study. I'm going to skip over this for time. This is just data showing that paradigm works very well, and we can, in both male and female pigs, identify robust neuropathic pain. I wanted to talk to you for a minute about this really exciting platform. 1 minute, I'm done. I'm going. Yeah, I have 1 minute. To talk to you about this exciting platform. And so we are developing this platform for studying neuromodulation with combination drug studies. It's in conjunction with Ann Parr, generously supported by these philanthropic groups here. And the idea is everything that you've talked about. You would have a platform then where you could look at doses of drugs, device locations, run different programs, different paradigms, looking at the the dose and drug-dependent variables, as well as the neuromodulation variables in a series of outcome models. So I'll conclude here because I'm over time, but our conclusion is that I hope that I have explained to you that we think that porcine models might be a really useful intermediary, right, between preclinical and clinical work, useful translational tools for combination strategies. Thank you for that support then, and I'll turn it over.
Thanks everyone for coming to take part in this symposium, and I can't imagine following a better talk than Dr. Floyd's, because I'm going straight out of here and we're starting a major collaboration using pigs, and it'll become clear during the talk why that is. But again, thanks for the invitation. What I'm going to talk about is summarized here, and I'm not going to read through things, but first starting off a little bit with personal reflections on spinal cord injury. First of all, it's all about team science and it's all about collaboration. So this is our research group down in Rochester, and I'm going to concentrate on the work of these four people: Igor, who is well known to you, Mo Biden, a neurosurgeon, Mahad Siddiqui, who's a PhD neuroscientist in the group, and Nick Madigan, who's a clinician scientist that works with us. And I didn't do any of this work. They did all of the work completely. It's all theirs. I only have two jobs. One is I'm a cheerleader, and I get money to support people. And if you're successful at that, everybody loves you. So if I can get the right button here, there we go. Everybody's familiar with this scroll from 5,000 years ago about spinal cord injury is a bad thing. The story is, this is my grandfather, and he had a fall and an accident in Hong Kong in 1948, a seminal year, because that was the year I was born. And at that time, the 5-year survival for spinal cord injury was about 5%. My grandfather made it 5 days. He never got out of hospital, and he died after 5 days. But we now know, now the prognosis for spinal cord injury for life is superb. And a 20-year-old who suffers paraplegia essentially has a normal lifespan, a little bit shorter for a quadriplegic. So an example of this is my wife's nephew, who had a trampoline accident, and unfortunately in a trampoline park landed on his head and got a C6-7 injury. So he's not quite quadriplegic, but almost. He recovered in terms of getting back to be able to live independently. He was in his first year of his college. It actually took him 5 years to complete college, but he graduated and now has a great job, lives semi-independently with the help of his parents, and does extremely well. So yes, we've come a long way in terms of patients with spinal cord injury, but we still haven't come a long way in terms of recovering the actual function of the spinal cord, which is where we come in and our interest comes in. And the only point I want to make with this slide, that everybody's seen something like this before, is that it's a very complex injury. And because of its complexity, it is likely that we will need complex and combinatorial type solutions. I originally came from a cell biology background. I'm a neurologist on the clinical side, but my background's in cell biology and kind of lived around the dorsal root ganglion for many, many years. And this is a very important cell because it tells us something. This cell carries all the sensory information from your hand to your brain, the afferent sensory information. If you cut its branch that goes out peripherally, cut your median nerve injury, that will actually recover quite well. You'll get regrowth and reestablishment of function in your hand. Not perfect, but quite well. If you do the same thing in the spinal cord, that's it. You don't see any regeneration or virtually no regeneration at all. So it's the same cell, so it's not a cell intrinsic property. It means it depends on its environment. And the difference where we come in, where our biology comes in, is understanding that difference in environment between the cell in the spinal cord and the cell process in the peripheral nervous system, and trying to recapitulate that in the central nervous system using combinatorial therapy. And the sort of things we're combining is we're using epidural stimulation in a rodent model. We're using biomaterials to build scaffolds for regeneration. We're using different kinds of cell therapies and gene-modified cell therapies, and specifically using the Schwann cell, which, colleagues, I spent time with working with Dick and Mary Bungie when they were in St. Louis before they went down to Florida. But they have studied intimately the biology and the importance of the biology of the Schwann cell in the possibly promoting spinal cord injury recovery. So we use Schwann cells, but genetically modified, and then small molecules that can be released from scaffolds that, for example, rapamycin in microspheres that reduces the foreign body response. And this is the model that we use, which is essentially a complete transection. So we're looking at recovery in a complete model in a rodent. We'll move on to pigs in just a moment. You can put cells in, you can put different types of cells in different channels. You can make those cells secrete different things to try and promote ascending and descending growth of axons, eventually to get recovery of function. So this is the core model. You can also use that scaffold and the area around it to sort of study in detail what's going on at the cellular level. We've started with lots of different types of scaffolds and looked at which ones work best in terms of their material properties, and OPF, oligopolyethylene glycol fumarate, with a positive charge on the surface, is something that, from a mechanical and a cell compatibility, has been the best that we've worked with up to this point. We can do lots of things with this. So we can modify its mechanical properties. We can modify its surface properties. It's biodegradable, so eventually it will allow the normal or the repaired spinal cord to come back. It aligns. You can align it with tracts in the spinal cord, and you can make lots of different designs. And I'll talk more about that in a moment. Sorry. So this is essentially the complex model that we're using, where I think you can't really see my arrow, but that doesn't matter. Essentially, the rat in the middle is the patient that we're using here. We've got rapamycin in the body of the scaffold being released from microspheres. We've got Schwann cells in the channels. In this case, they've been transfected with a vector to make them secrete GDNF, a neural growth factor. And then we can use epidural electrical stimulation as well, which I'll talk a little bit more about. So the actual experimental setup is complex. This is all Dr. Lavrov's work in terms of the physiology and being able to do the kinematics of the rat in sort of free walking in an environment where you can measure both the effect of stimulation and do joint kinematics as well. So this is just an example of what this looks like. So the top left is 1 week after a complete transection injury, when a scaffold with all those things, and the bottom left has been put in. Whoops. How do I make it? Sorry. I'm a Mac person, so you put me on a PC and I'm dead. Yeah. So that's 4 weeks with stimulation, and if I can make the top one work, see if I can do it a different way. No. Well, it doesn't matter. The top two can hardly walk at all on the treadmill, and as you saw, the bottom one walked quite well, so he's going to do it again. There we go. Looks good. So you can combine electrical stimulation with these other modalities. You can also do physiological recording through this as well. And I'm not going to go through this in detail, but the type of detailed physiology that Dr. Lavrov and his colleagues in the group can do allows us, if we look at, if we just concentrate on the top curves, the top electrical response there, we're recording from one of the leg muscles and stimulating either at T8 or at S1. And 1 week after injury, you can see there's no motor response when you stimulate above the injury, which is a transection at T10 level, whereas you get a normal motor response below the injury, stimulating at S1 level. 6 weeks after the injury, you can see now we've got a motor response has returned in the second column here, 15.5 milliseconds. And when you stimulate again, stimulating at the S1 level, you see that the motor response is there, but it's more complex. And then importantly, after retransection, so now you retransect, you can see the motor response in the muscle when you stimulate at T8, that's gone again, as you would expect, but that shows us that some sort of information is passing through the scaffold. But that complexity of the response in the when you stimulate at the sacral level tells us that something's happened about the reorganization of the circuits in the lumbosacral region, in the region of the gate generator. Now, so we can say that suprathreshold stimulation is influencing sublesional recovery or reorganization, but this doesn't actually increase the number of axons generating through the scaffold. Now, if we look at that sublesional synaptic organization, and again, this is a very, very sort of big overview, what we see is that there are a lot more synaptic boutons on both interneurons, so calbindin positive interneurons, and on CAT positive, cholinestyltransferase positive motor neurons. So something's happened to the sublesional circuitry as in response to the stimulation. Now, subthreshold electrical stimulation, so this is with implanted electrodes in the rat, but not giving the stimulation at a level that doesn't evoke motor responses, but which can be given for much longer periods of time. And again, thinking translationally, so this would be something that rather than just being done in therapy sessions with a therapist, it could actually be done on a longer term basis and even potentially at home. So what we're looking at now is how does this affect the biology? And again, what we find is that the addition of subthreshold stimulation actually doubles the number of axons regenerating through the scaffold. So in terms of axonal regeneration, we're getting twice as much axonal regeneration. And interestingly, it significantly reduces the amount of inflammatory response measured with iNOS staining, either total iNOS staining or the number of iNOS stained macrophages, or microglia rather, below the level of the injury. So it's doing two things that, we don't know exactly the mechanism of those yet, but two things that we believe are positive. And it also makes a difference to function in terms of acutely, so this is 6 weeks after the injury, you can see in time after the injury, that switching the stimulation off or on is having an acute effect as well as an apparent chronic effect. So, how do we get this? And this is, I don't have to say anything at this point. The only place to go next is to pigs, okay? Because if we want to get from mice, for all the reasons that Dr. Floyd said, totally agree with those, anatomy, physiology, the pig is the animal to go to. After listening to Dr. Floyd's talk, all about Charlotte's Web has become clear to me. So, You can tell I've got lots of children and grandchildren. We also have the advantage, or the nice thing at Mayo, is that we've got a GMP facility for biomaterials. And that's going to be incorporated into our next step where we're thinking about, okay, we've got a lot of biology from the rats. Now let's go and we'll move on to the pig model. But let's make everything we do in the pigs as human-like as possible. So the scaffolds that we make for the pigs that go into the pigs will be made under CGMP, just like there would be for a human scaffold. So where AHAD continues, Dr. Siddiqui is continuing with the more basic biological, trying to understand the mechanisms of these changes using isolating extracellular vesicles from spinal cord and blood in injured rats, in this case. It will move into pigs. And seeing that electrical, oops, I think that means my time ran out, is that right? So anyway, so the electrical stimulation changes what's in the extracellular vesicles of human-derived motor neurons in culture, IPS motor neurons. My colleague Nick is this is a collaborative study with folks at the University of Minnesota, which is in embryonic development, but this is essentially to use decellularized spinal cord extracellular matrix. But the novel twist on this is we're really interested in what's the difference in the extracellular matrix of the spinal cord in the developing embryo to very young animal to the adult. Because it's in the embryonic and young animal, the young pig, that the environment is promoting regeneration or growth in the long axonal tracts. So it's to look at extracellular matrix from the spinal cord of swine at that critical period when their long tracts are developing, then to look at the difference of the adult, and then see if he can simulate the sort of, I'll call it embryonic, very young age spinal cord in a scaffold environment. And as I say, this is a proposed collaboration between Anne and colleagues at the University of Minnesota and our group. And then Igor is doing very interesting studies, and this is an ongoing study, again, trying to think of a translational aspects of taking blood from pigs, leukoconcentrate, triple modifying it with gene vectors, and using that in the swine model. Mo Biden is moving on. His first phase study of MSCs in spinal cord injury patients was published last week in one of the Nature journals, which showed some improvement. And Mo is moving this on into phase 2 and phase 3 trials. And it's just to say that, yes, we're working at a very basic biological level, rats to pigs, but part of our group is also doing human clinical trials as well. So I think we can sort of conclude, and I won't read the conclusions, you can read through those, but it's really the message is, number one, that it's only by combination and combining these different kind of modalities that we really will get significant improvement in function. And I don't have to do anything to sell pigs. So again, I'll just say thank you. Thank you to the team and thank you to our funders. And questions later.
Thank you for the invitation to be here and present on the beautiful symposia, and thank you, Igor, for your introduction. Yeah, it's a great honor for me to be here. And Igor was my PhD student, first PhD student, so I am very happy that he has beautiful progress in this area. So I will talk about multi-site and multifunctional spinal cord stimulation. And in Reggie Edgerton lab in UCLA, we demonstrated that in spinal rate, complete spinal rates, the locomotion can be induced by stimulation L2 and S1 spinal segment. Now you look this spinal rates works better than intact animal. And no stimulation, no locomotion. Stimulation one side induce this pattern, additional stimulation can modify pattern. So this is a very important observation about combination, different side stimulation, and integration, because this one side stimulation is addressed to the CPG, and another more caudal area addressed to the postural locomotion, postural network, and combination to provide very good postural locomotor adjustment. So this data, it was a basic for our next step, and we have developed transcutaneous stimulation in my lab in Russia. So in 2012, we developed the technology for transcutaneous stimulation initially in non-injury subject, and we demonstrated the special condition. This is a gravity-neutral device with the suspended legs. So stimulation between T11 and T12 is able to induce some rhythmic locomotor-like activities. This area, very specific, is similar as during stimulation. This is the localization CPG, is a L2 spinal segment. And in all our non-injury subjects, we induced locomotor-like activities. Interestingly, we facilitate this activity when we stimulate simultaneously different areas, including cervical level, lumbar level, and the caudal. So now you can see the initiation movement during stimulation T11, and then additional stimulation L2, which is localized postural network, improve locomotion, and when we stimulate additionally cervical level, the pattern is changed and more coordinated like this. And in some guys, he cannot stop. Okay, stop please locomotion. He cannot do it. So it's very strong activation, CPGs, and during different side stimulation, it was really strong locomotion. So, and then we go to the subject with the Reggie Edgerton, also in UCLA, and we stimulated T11, T12, we localized CPG, and coccyx, and this is a very nice area for modulation, neuromodulation, additionally locomotor circuitry, and we have. So what's the? How go forward? Oh yes, and we have 5 spinal cord injury patients, Asia A, and we the treatment was 20 weeks, and this is 3 stages at the beginning, inducing locomotion in gravity-neutral device, then training and maintenance, and at the final stage we use additionally 5-HT2 non-selective agonist buspirone. So, and at the beginning, when we studied stimulation, the pre-training, nobody can perform voluntary movement. And in the presence of stimulation, yes, we can induce some rhythmic, and during combination stimulation, two areas, it was more effective for inducing locomotor behavior. This AMG recording demonstrated the first stage is nothing. As I said, it was impossible to initiate voluntary during first session, and then post-training during initiation and maintains. So the all subjects were able to induce some kind of rhythmic activity, but at the final stage, in the presence of buspirone and stimulation, those are 2 areas. So it was possible induce stepping movement without stimulation, and in the presence of stimulation, it was strong facilitation. This is a histogram about the displacement of knee joint, and you can see at the final stage, the the amplitude increase in 5 to 6 times. So this video demonstrates what I said. The first stage video, yes. So before treatment, the subject tried to perform voluntary oscillation. It was nothing like this. They tried initiate voluntary movement. But in the present stimulation spinal cord, 2 areas. So all subject with the AGA can induce some kind of course, it is not stepping like this rhythmic activities, and after treatment with the buspirone administration, additionally, all subjects can perform some kind of voluntary activation like this, and during stimulation, it was strong facilitation. Yes, this is voluntary plus stimulation spinal cord. Next step was using not only this special condition, but now we have an age project, and we treatment 2 subjects with AGA, 1 subject with AGA, and second one AGA-C. And we have 3 paradigms. So this is a gravity neutral device for inducing rhythm, for formation, rhythm generation system for activation, then treadmill walking, and overground stepping. And we have, additionally, we have buspirone administration in each stage, and we stimulated, in this case, at cervical level to reactivate descending system. We stimulated T11, T12, we localized CPG, and also we stimulated the level L1, L2 to provide the postural adjustment and to regulate the muscle tone. And finally, we stimulate coccyx. In general, we have 5-6 area stimulation, and we combine this area for looking the most effective stimulation for inducing locomotor behavior. This is the AGA-C subject. He has a same paradigm, gravity neutral, for 1 month and 3 months stepping in treadmill and overground independent stepping. So what we have, so the same as the previously we observed very strong facilitation after treatment. Initially, same story at the beginning. It was nothing. It was impossible to induce voluntary movement. And then at the final stage, they very easy perform a rather coordinated stepping-like movement. So this is a displacement in different joint. And you can see it at the beginning was nothing, and finally you have nice coordinated stepping movement. AGA-C demonstrated same, improved significantly this characteristic of kinematic AMG characteristic, pre-training and post-training, and this AGA and AGA-C, and you can see huge difference between initial testing and final testing. So this is the parameters of AMG activities and in both subjects. So this video shows initial testing. Just when we started to practice with him for overground locomotion. This is 1 month after overground locomotion. He tried to walk this AGA with the assistance, but this 6 months later, the stimulation off. So this is the first stimulation on, the stimulation on, off, and you can see he performed almost independent, with just only a little support, a little assistance, but almost walking independently. At 9 months, at the final testing, so I also can walk, also without upper lip control, and and also he tried to walk independently using walker. Most dramatical was for AJC, and this is the first testing, 10 meters walking, so with assistance, without steam, and immediately stimulation. This is a three-side stimulation, three-side area stimulation facilitated walking, and if you look, this is the time for 10-meter test. So what is this time? So the baseline, and this is during stimulation, so the time was shorter significantly. And same story for 6 minutes test. This is the final testing. He walks independently, completely walking using the walker, but he walked very, very nice. So it is good results, and we decided with Professor Berman to use this technology, multi-site stimulation, for the kids with a spinal cord injury, and we believed, okay, maybe the kids huge plasticity, synaptic plasticity, muscle plasticity, and we use this technology. And in general, technology was very successful. It was the same three paradigm: gravity neutral device, walking on the treadmill, and walking over ground. And so we have 20 sessions in gravity neutral, 40 from 40 to 40 sessions for this combination. And we have really very nice results. So all these kids, we have 4 spinal cord injury kids with AGA, and at the beginning, we help perform voluntary movement, but immediately after practice, all kids were able to perform voluntary movement. And they also can walk on the treadmill almost, again, I'd like to emphasize almost independent, and same story for over-ground locomotion. And interestingly, all this is a subject. They were able to perform voluntary in unassisted swing phase, but it was very difficult to perform stance phase. So the problem is they cannot make propulsion. So during stance phase, the trainer helped to perform stance phase. This is the rule. This is correct for adult spinal cord injury guys and for kids. And we started to thinking about new technology, how we can control not only initiation locomotion, how we can control the specific phases, the stance phase and swing phase. And we developed this as a system using this Russian spinal neuroprosthesis, and we stimulated midline for inducing and controlling. This is for inducing locomotion. This CPG, this is a triggering zone. This is a stimulation for control the posture and muscle tone. But additionally, we stimulate laterally 2 electrodes. So this area for initiation swing phase, and this area for initiation stance phase. So we have trigger from gyroscope, and we trigger for swing phase for stimulation flexor motor pool, and during stance phase we trigger to stimulation extensor motor pool. So, and you can see this L1 stimulation for stance phase, And there's a clear effect of activation, extensor pull for stimulation, more rostrally for activation, effectively activation, swing phase, and this combination. What is a normal, non-injury guy, normal? He is walking without stimulation right now. Now we stimulate the extension, left extension. And you can see how he performed propulsion, real propulsion. And this stimulation for flexion, and the stimulation more rostrally, and left side again, looking left side, and now he starts stimulation, and he start each cycle we trigger this swing phase. And this combination, swing, stance, phase. In no stimulation, and then start stimulation, stance and swing. Yes, left side, look this, stance, swing, stance, swing, stance, swing. So this is a transcutaneous stimulation. It is not selective like epidural. So the big electrode is 2 centimeters, but same time we can activate the pull which is dominate for function. So we can activate more specifically flexor or extensor motor pull and control. So this is our last theory, big theory about multi-site stimulation. We stimulate the cervical level in order to reactivate descending system. At the same time, we activate cortical network, and we demonstrated yes, the stimulation this area can activate cortical structure. And also we have activation the CPG at T11, T12. We have, this is 4 electrodes for activation, flexor extension during swing phase and stance phase, left, right side, and finally we have the coccyx. So we integrate the different system to provide, not normal of course, but provide effective locomotion. And very interesting, this is a naive guy, no practice, no training at all, first testing. So there's during selection. So, and actually he cannot walk. So there a lot of assistance during helping. And then start immediate stimulation, almost independent, without practice. But this is a complex stimulation, cervical, coccyx, rhythmic stimulation, left, right side for flexor extension. And this is a combination, continuous and rhythmic. This is a subject can stand, he can control posture, and then perform stepping-like movement. Again, this is very important for me. This, because we know all theory about neurorehabilitation is a lot of repetition. So because the plasticity is then more than better. So this is not the case. So in this case, we can activate different system and integrate system to control locomotor behavior. And this is my last part. So this is a young guy. He has diving injury at cervical level. And after surgery, he was 1 year. Actually, it was during COVID, and he was actually without any practice and rehabilitation. So this is we can say this is spontaneous recovery. I started to work with him when he was in this situation. He can stand a little and try to walk. And after 1 year, he started to walk like this. The mom control him, and so can regulate the balance. This is no stimulation. Look, this stimulation again, all areas. How he can walk is very stable, very robust stepping during stimulation. Again, cervical, lumbar, thoracic, and rhythmic stimulation left-right side for leg extension. And 5 months later, he can walk independently. And this is 1 month ago, the last testing, he started to walk independent. So my conclusion about synergistic activation, different locomotor system, it is very important synergistically. How it doesn't matter which synergistic will be effective. I mean, if we stimulate at lumbar, at cervical level, we activate descending system and interleap coordination, intrinsic properties, etc., etc. Then more synergistic activation, which is related to locomotor behavior, will be better. And I hope this is a theory, this is a technology have impact for rehab, and I am looking forward with optimistically, and we'll see in future. Thank you very much. With my colleagues, Reggie Edgerton, Susie Heicherma, Andrea, and this is my pupils.
Thank you so much. So I think we're going to have a Q&A now. People that have questions. So maybe, do we have a moving mic? Yep, we do. So anybody who has a question, just put up your hand and we'll address that. Okay, well, I'll start then. I'll start the discussion. And so what do you think about acute versus chronic spinal cord injury? Like, do you think that we should be doing these treatments earlier in patients, or kind of waiting until they've had their natural recovery and then moving on?
Of course, it is in early stage, it was easy, but so the revolutionary paper in 1991 is from Miami project about the Candance. They published paper in Brain, and they demonstrated that the subject, after 17 years after spinal cord injury, and after they started to work with him, and he demonstrated some automaticity, blah, blah. After 17 years, it is a huge reorganization, spinal cord, whole system, but nevertheless, they can some improve locomotor function.
Okay. Dr. Windebank, what do you think?
I think there'd be different approaches during acute, in the acute phase of the injury and in the chronic phase of the injury.
Oh, yeah.
And I think in the acute phase, then I think looking at elements of whatever kind of therapy, whatever kind of biological manipulation you're giving, to sort of try and manipulate the biology of the system to encourage as much decrease inflammation and increase as axonal regeneration during that period, and by that sort of period, at least 6 months after the injury. And then after that, I think then the physiological stimulation and ongoing, exactly as has been shown, the sort of it's like doing therapy, but instead of doing therapy for just short periods of time, that you can actually think about with integrated stimulation, especially the kind that we've just heard about, doing this on a longer-term chronic basis as well. So I think the therapy, the intervention will change with the time after injury.
Yeah, absolutely. Yeah. So I'd like to emphasize, this is a system which I'm thinking how name. So this multifunctional stimulation with elements of prosthesis, so because we dictate left, right, go, at the same time we stimulate the circuitry. So this is a combination between neuroprosthesis and neurorehabilitation. And this, I think it is important for recovery and et cetera, et cetera.
Okay, Dr. Floyd, do you have any thoughts about the
Yeah, I
acute
mean,
versus chronic?
I
in
think
pigs?
similar. I think that I would approach it from the drug plus neuromod approach, and of course, drug approaches at an acute time point are going to target different therapeutic targets than they would at a chronic time point. So plasticity targets will be very different. So I think that, combining the therapies, as others have said, in a way that takes into consideration underlying pathobiology is a reasonable approach.
Okay, well, any questions? There's one over there.
As far as translation into the human model from the age-old adage of mice lie and monkeys exaggerate, where would you guys put the pig in that spectrum?
So I think that pigs are a really useful model for a lot of the research components. There obviously are a few limitations, right? But I think that pigs are, we talked about this earlier, so when you add a multimodal assessment of outcomes in pigs, they have very true signals. So again, vocalizations are a true signal or an honest signal. As characterized, pigs don't have a socioeconomic reason to change their pain score or things like that. They do have social hierarchies and complex emotional states. So I think that that's a very nice model to be able to incorporate individual differences. So I think that it's interesting that pigs are probably somewhere between. I've certainly been outsmarted by my pigs many times, embarrassingly to say, but I think that they're not quite the manipulators that monkeys are for a system. And the other thing I'll say is that the pioneers that have worked in pigs before me really established highly clinically relevant models. So these are big lesions, these are paralyzed animals, they're relatively equivalent to an Asia B, sometimes an Asia A. So that's a fantastic model that you may not be able to afford in a primate that would have a much smaller lesion because of the complexities of animal care. So I think that the pigs also offer that very physiological size and complexity and severity of the lesion that you don't see in some of the other models. Of course, they're ungulates, right? So they don't have hands, right? So hand function is not something that you could evaluate in the model.
Maybe I can add on this issue. So I think we also have to consider that pig model provides quite close to what we call discomplete injury, because there are no other animal model. Even monkey, there is no monkey model which is discomplete, right? We can do only hemisection. So what we see in pig, if you do even moderate contusion at thoracic segments, they completely paralyzed forever. Yeah. And then when you stimulate lumbar segments, they became able to step. Yeah. So again, this is much closer to human discompleteness compared to even monkey model. Yeah. The only question here, if this is really could be connected with volitional corticospinal path. And I also wanted to ask Dr. Floyd, so what's your experience on this pedal project? And can you really say that after spinal cord injury, there is a volitional pathway that could be damaged or recovered?
Yeah, so thank you. So the question is about, can you measure volitional movement in pigs? And so we've been talking about this for some time. So we have a prototype where we've developed a pedal that also has pressure sensors in it. And I can easily train pigs to volitionally press the pedal, like I said, for a jelly bean or whatever, And so we're just starting to look at, so basically I put the pigs in a pen pinto sling, so they're in anatomical position, and they're able to, after spinal cord injury, look at depression of the pedal. So the data is incomplete, and we're still developing the model, but I think that the tools to assess volitional movement in pigs could be readily developed. And I mean, with additional sophistications, as far as training the task, it takes me like a week to train a pig to press a pedal to get a jelly bean. So there's no question that they're motivated to do the task. The physiological and human correlations of that need to be better described, and that's under development.
I think also anatomically, Igor did a very nice study published a couple of years ago where he compared in detail the human anatomy with the pig anatomy from human autopsies to pig autopsies, and showed that the pig is much closer anatomically to the human than the rat is. So I think, to me, it's a logical translational step between.
Okay, I think I saw a hand up back. Sorry. Oh, I guess you. Yep. Go
So my question is for Dr. Windebank, but also everyone in general. You noted that with spinal cord stimulation, you actually saw a doubling of the number of synaptic boutons and also a doubling of the number of axons that grew through the scaffolding. So my specific question is, did you see any neurotrophic factors or any kind of chemical markers that would cause like kind of that correlation or causation that relates to that plasticity? Were you able to like draw that line?
No, it's a great question. I think the answer is specifically not at this point, but that's something that we're very interested in, kind of understanding is, as you said, at the molecular level, what's the mechanism of why the subthreshold electrical stimulation is increasing, both the number of axons, doubling the number growing through. So it's clearly having, in the sublesional area, very significant biological effect, and sort of by dissecting that out, hopefully we'll be able to isolate factors where, you know, independent of cell therapy, then you can put those factors in.
So sorry.
Gotta stand up.
Okay. That's how it works. So more broadly to the group, have any of you been able to identify any factors that, in addition to environment, as in like on that level, that impact the plasticity seen within the spinal cord?
So I can actually answer that one
say,
because
I'm-
I haven't
yeah,
spoken
Anne's supposed to
too much
ask.
about this, but and just to give a shout out to my researchers on the front row over here because they're responsible for much of this work. But we have a rat model of tail nerve stimulation, which is akin to epidural stimulation. And we found a few things. One is that there was an increase in serotonin in the lumbar cord after epidural stimulation, or well, it's tail nerve stimulation in the rat. Another thing really interesting is that if you activate axons, we already know that that increases oligodendrocyte myelination, so it's insulation of the nerves. And so we also found an increase in myelination in the distal cord. And as you did, we also found an increase in synaptophysin, so that indicates, you know, synapse formation. So those are the three major findings that we found in our rodent model of tail nerve stimulation. And I think someone up over there too also put up their hand.
Great presentations. I have two questions. So one is piggybacking off the last question. Do you have a hypothesis about why you would see more axonal growth or more axons with the subthreshold versus the suprathreshold stimulation? So that's question one. And then Dr. Gerasimenko, I would love to hear what you believe the coccyx stimulation is contributing to multimodal stimulation. Thanks.
So for the first question, my hypothesis would be that the subthreshold stimulation you're doing for a much longer period of time. So you're kind of stimulating cells in that, we're called in that sacral region, on a chronic basis, as opposed to the intermittent treatment that you're giving with the suprathreshold. And that subthreshold, it's kind of understanding what's the difference in the biology that happens in the cord between the suprathreshold and the subthreshold, you know, looking at the kind of things that you mentioned that will really, you know, help us tease that out. That's the first part. Now the second part.
Thank you for this question. When I suggested stimulate coccyx, they say, Yury, so it's ridiculous. Why you will stimulate this area? Is no spinal cord, etc. I say this area for tail, and also this atavism for us. But we have all connection is dormant, is not working. But if you activate, it will be worked because for monkey, for example, it is the tail. It is a fifth leg for the balance control, for everything, very important. And when I stimulated coccyx, it was so strong neuromodulation. I think it is input very, very important. So, but again, my interpretation, it is the area of the tail.
Your wagging tail.
Just one out. So those who work with animals quite know that whenever you want to induce locomotion, you pinch the tail. It works extremely well. And may I ask you one question, Yury? Yury Petrovich, so what do you feel about epidural stimulation? Do we need it at all? Do you see any future for epidural stimulation, or transdermal stimulation could cover all needs?
No, I think what is working synergistically, it is okay. We published with Claudia a nice paper about combination. She stimulated epidurally at lumbar, and I stimulated cervical transcutaneously, and we have beautiful results because even AGA immediately stimulation above site of injury, so we facilitate descending dormancy, which is not working without stimulation. And we observe nice improvement and facilitation locomotion when she during this two-side stimulation. And I think the different combination. So, you know, in Russia, we use the stimulation, the mechanical stimulation foot receptors. So this is for space flight to prevent muscle atrophy. So this also very important input to the locomotion, because we live in gravitation. So we live in gravitation, and this is the activation of these receptors so important. And I think this is a problem which I mentioned for propulsion, for regulation. So the stance phase, we can decide also using additional stimulation, mechanical stimulation, the foot receptors as well.
Okay, I think there's a question back here somewhere.
To the group, somebody 20 years post-injury, nearly 70, I just need to express my gratitude. You give me hope and purpose, inspiration. So thank you.
Thank you.
Okay, I think there's a question back.
Thank you for presentations. I have a question related to the stimulation levels, and actually two parts of the questions. In the presentation, you know, there's adult population and there's also pediatric population. Did you notice a significant difference from perspective of the stimulation parameters and levels that you needed for pediatric population versus adult? That's first question. And the second question, as you follow up your patients, you know, 1 month, 3 months, 6 months, did you have a need to titrate your therapy parameters or adjust them over time to optimize the delivered therapy? Thank you.
No, it's not different. So with Professor Bergman, we go step by step. So we started the stimulation. There's a 3-area midline stimulation, but we are planning to use the same rhythmic stimulation, controlling same as for adult. And so this stimulation is very tolerant for the kids as well. And so because we use this is a modulated pulses, and for kids no problem, the spinal cord stimulation. And now we know how to go forward effectively with the kids as well, and we will do it.
With that, I think we have to end. I'm sorry if we've run out of time. So let's thank our panel one last time.